This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello, and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, Senior Attending Neurosurgeon.
And I'm Dr. Alara, Research Fellow. Today we're looking at a fascinating new study from the journal Medicine, published in 2026, titled Clinical Outcome of Gamma Knife Radiosurgery, GKRS, for Indirect Carotid-Cavernous Fistulas, CCFs.
This is a timely topic, Ilara. We've traditionally seen gamma knife as an adjuvant or last resort modality for indirect CCFs, something we use when endovascular embolization fails or isn't feasible. But this paper by Cohen Park really challenges that hierarchy. It looks at GKRS as a standalone primary treatment.
Exactly. For our residents and students listening, let's just quickly set the stage. An indirect CCF, as opposed to a direct high-flow traumatic fistula, is a low-flow pathological shunt. It's an abnormal communication between the cavernous sinus and the branches of the internal or external carotid artery.
Right, and as the paper notes, while they are low flow, they are far from benign. If not treated at the appropriate time, these can lead to blindness, secondary glaucoma, cranial nerve paralysis, or even cerebral hemorrhage. The goal is to detect the condition early and treat it with less invasive methods to minimize patient discomfort.
The study itself was a retrospective chart review of 20 patients treated at a single institution between 2017 and 2023. What I found impressive right away was the mean follow-up duration, 47.4 months. That gives us a very solid window to look for recurrences or late-onset radiation complications.
Let's talk about the patient population and how they were classified. They used the Barrow classification, which is standard for our board exams. Ilara, how did the 20 patients break down?
Of the 20 patients, 6 were classified as Barrow type B, which for the residents means dural shunts from the internal carotid branches. 10 were type C, shunts from the external carotid branches, and 4 were type D, shunts from both the ICA and ECA branches.
So a good spread of indirect types. And before they even got to the gamma knife suite, what were these patients presenting with?
It was a classic ophthalmological presentation. Eyelid edema was the most common symptom, seen in 19 out of 20 patients. 16 patients had elevated intraocular pressure, IOP, with a mean IOP of 27.7 millimeters of Hg. Some went as high as 42 millimeters of Hg. Other symptoms included chemosis, exophthalmos, ocular pain, headache, and diplopia.
That's a significant clinical burden. Now, let's dive into the technical aspects of the GKRS itself, because this is where the precision matters. The paper describes using the Lexel gamma knife perfection. Walk us through the planning.
This was interesting. They performed the GKRS in a single fraction with a stereotactic frame. For the first 10 patients, they actually used digital subtraction angiography, DSA, to define the target boundary. However, for the last 10 patients, they shifted to using magnetic resonance angiography, MRA, TOF images, time of flight, as the primary imaging for planning without the need for DSA.
That's a notable shift toward a less invasive planning workflow. They delineated the target by looking for the area that showed an early high signal change compared to the normal cavernous sinus. They restricted the target area along the involved cavernous sinus wall. What about the dosimetry?
They used a marginal dose of 16 to 18 gray, typically at the 50 to 60